Hello, hello. Hello, everybody. I am going to give you all just a minute. Get connected. We have a lot of people popping on today. So I will give you all just a second as I see a lot of connecting to audio, a lot of pictures popping up on my screen of people's faces. So good to see you. Give me a smile. Give me a wave. It's good to see all of you. Happy Friday. So I'm very glad to have you joining us today. I think today was a hot topic. We had a lot of people register for this. So with that being said, I'm going to invite you to go ahead and open up that chat box so that we can start tracking your questions, because I'm sure you're going to have them. And this is going to be a conversational style program. And we're going to allow these questions to kind of be interspersed through the conversation today. So as we go through it, if you have a question, I'll try to ask that of Dr. Samanta as we go along. And yes, please give me a shout out and let us know where you're joining us from. Oregon says it's already getting cold. Some of you are experiencing fall. Some of us, such as Dr. Samanta in Arizona and I in Florida, we're not really experiencing that much fall. So at least not yet. So we love to hear where everyone's from. And because we have so much to cover today, I am going to go ahead and introduce our speaker, Dr. Samanta. Some of you may have recognized him. He was on recently with Dr. Lori Mishley when we did our cannabis talk. And today we're going to be talking about pain, cramping, lots of pain issues in Parkinson's. He's a movement disorders neurologist in private practice in Phoenix, Arizona. He's also a clinical associate professor of neurology at the University of Arizona College of Medicine in Tucson, and a clinical lecturer at the Phoenix Medical School in the University of Arizona. So Dr. Samanta, welcome.
Thank you. It's a pleasure to be here. It's always great to work with PMD Alliance. So,
well, awesome. So I'm going to go ahead and get started. Let's start off first by just delving into. There's all kinds of types of pain, causes of pain that we can experience with Parkinson's. So let's start with maybe some of the musculoskeletal types of pain.
absolutely. And I mean, even though just sort of to kind of start off a little primer is, even though we don't, it's not, pain is not necessarily one of the original symptoms described with Parkinson's. There's still a great deal of folks who have Parkinson's who would, who report pain. Up to 75% of people with Parkinson's are dealing with some degree of day-to-day pain issues. So, and I think probably in a lot of ways the most common form is musculoskeletal, and and so I sort of call this type of pain, this is the cost of living pain. These are the aches and pains in a lot of ways that we earn just from having lived our life. That's the old sports injuries from 30 years ago. It's the, having, worked in construction or, stood on a concrete floor for 20 years at your job. Those are all things that add to, arthritis changes in your, in your knees, your hips, your back. And so, in some ways you can say, well, these are not directly part of Parkinson's, but they certainly do, there is an interaction there. Let's put it that way. If you hurt and you have Parkinson's, well, so now that causes you to move a bit more slowly. It certainly affects your ability to get in and out of a chair, especially if your Parkinson's is also affecting that. And then the flip side is, if you're having more rigidity, well, that causes some muscle and ligament tightness and shortness that can cause musculoskeletal pain. And it can aggravate, the arthritis in your back that you already have. et cetera. And so those are, you know, the day-to-day kind of most common, most sort of typical pain for anyone, but also a very significant impact potentially in, you know, in your Parkinson's. And really the management is maybe in this case a lot more focused on, you know, the general management of these kinds of issues, whether or not you have Parkinson's. So if it's back pain, it's, you know, it could be physical therapy, it could be stretching, it can be, you know, anti-inflammatories if those are appropriate for some, you know, for folks, heat, massage, but also more interventional therapies. So, you know, it can be a joint injection, it could be a cortisone shot, you know, in a facet joint in the back that's inflamed. And occasionally it involves surgery. If, you know, if you have bad enough, arthritis in your knee, and that's becoming the number one issue in terms of your mobility, it's, you know, it's no less reasonable, I would say, for someone with Parkinson's, you know, to have a knee or a hip replaced than, you know, than someone without it. And I would even argue with the importance of mobility to maintain our independence and our function in Parkinson's, in some ways it might be more important for someone with Parkinson's to address that sort of an issue. Whereas maybe 30 years ago, I think there was a lot more hesitancy about whether or not people with Parkinson's were good candidates for things like knee replacements or hip replacements. I would say these days, if there are no other contraindications, you know, you've got a fairly healthy heart, you've been reasonably active up until that point, doing the things up to and potentially including a joint replacement that will allow you to be more active and mobile are actually quite reasonable and important. So
I had a thought about that. So
Mhm.
the more you sit, the tighter that you get, like your hamstrings get tight. And if you're dealing with somebody who might be fatigued, have apathy, and they don't get up and move, it becomes like a vicious cycle, because then that can increase their pain. So, you know,
Absolutely. Yeah. And I think sometimes the last thing you want to do when you hurt, you know, is exercise or get up and move. And yet it's, you know, you can look at any, you know, physical therapy, manual or textbook or physiatry textbook, and everything is based on getting people moving. And, you know, we need muscles to be as strong as possible to help support our posture and take pressure off of joints. We need flexibility and strength. And the fact is that oftentimes we hurt more when we are deconditioned, and out of shape, or sedentary, than if we are active. But there is often, an uncomfortable transition in the early going as you start to, use muscles that aren't used to getting used as much, and stretch ligaments and tendons and muscles that haven't been getting stretched as much. So, I think at the end of the day, with things like musculoskeletal pain, some of the most important things you can do is stay in shape so that you don't get into that kind of sort of a spiral of pain and then deconditioning.
So maybe starting therapy earlier and encouraging the ongoing exercise and therapy intervention as needed from the very beginning might be a really good approach.
Yes, yeah, I think so. I think more and more, philosophically, we are seeing that, there isn't anything to be gained by maybe, watchful waiting when it comes to a lot of symptoms, pain being one of them. Anything that potentially restricts or inhibits your activity and your engagement in the world, is something worth trying to address as early as possible. And really, when it comes to exercise, what you're really trying to do is proactively prevent these situations from ever even developing as best as possible.
All right, well, we have had a few questions, so I'm going to go back to those before we move on. So one person, actually two people, were asking in regards to surgery. So the first question, would these surgeries like the knee replacement, hip replacement, whatever, not be more risky for those with more advanced Parkinson's? And is that a consideration? And again, another person added to that, like, since it's a stressor on the body, and stress tends to exacerbate Parkinson's, how do you reconcile any surgery, regardless of whether it's a cataract surgery or a knee replacement or whatever?
Sure, and honestly, this could almost be its own topic, but so, I think number one, surgery in general, most, especially orthopedic surgeries, have really advanced over the years. Many can be done with sedation and a epidural or a block. I've had many patients, over the last 5 years who've had total knee replacements without having to undergo true general anesthesia. And so, there isn't anything, the worst thing about surgery in general is actually general anesthesia. And that's not great for anyone. But there have been papers in the orthopedic literature published in the last 10 years that show really in a patient with Parkinson's who has been reasonably active, and that means ambulatory, and able to ambulate independently, so that's not a high bar for for activity. That Parkinson's patients seem to not have any worse outcome with knee or hip replacements than the general population once you've kind of corrected for age and other medical issues. So the real issue is just, is this person physically strong enough to rehab, and whatnot. So yes, there may still be, for someone who is in a wheelchair, is not able to get up and walk on their own, well, that person may be somewhat less likely, to have a good outcome or have as good a recovery from surgery. Again, I think it has more to do with their general body state. And I think that's the primary concern. The stressor on the body, there really isn't much evidence to suggest that stressors, whether they be surgery, life stressors, pneumonia, what have you, that they cause any significant advancement of, progression of disease in the brain. Now, people have physical setbacks, but those are because of things like deconditioning, loss of weight, loss of strength during the illness or during their convalescence. And those are things that with enough, with sort of very diligent physical therapy, rehabilitation, and a little bit of good luck, one should be able to recover from. And hopefully an otherwise healthy person with Parkinson's certainly should be able to recover from. I think the only other area that can be of concern specifically for Parkinson's may be if you have some cognitive impairment, or you've had sensitivity to pain medications and they've caused confusion in the past, one would need to be more careful, again, more about the anesthesia and the post-recovery pain meds and those things, that you don't end up in a situation with kind of a delirium or post-op or hospital kind of delirium or confusion. But that's actually relatively rare with Parkinson's still.
Thank you for answering that. I had a question about sleep position. So they want to know, is there a preferable sleep position in effort to promote good posture? So this person says they sleep on their left side, knees pulled up, and they're curled forward. Can that contribute to pain? And sometimes you can't really control how you're sleeping at night. You just move and you're sleeping, but.
Right. I think maybe in its most extreme form, it can. I think probably if it's a comfortable sleeping position and you're not sleeping 13 hours a day, in that position, I think the position that you sleep in bed is probably not, it's probably very rarely a contributor. Now, I think, a larger proportion, than I think we realize of folks often sleep in their recliner, in, sort of halfway upright on their sofa for big chunks of time. And I think that's probably more likely to contribute to pain, just because you're more apt to sort of be slouched over, or your back muscles may be stretched in a very awkward way. But I don't know that there's a perfect or general perfect sleeping position. I think if you find that you are very, very tight, sore, achy in the morning, and you tend to sleep in one position, it may be good to that may be a situation where you want to explore, gee, what if I, try to lay more on my other side, or start the night out on the other side, or maybe use some strategically placed pillows to sort of add some cushion and some support in, for various areas where maybe the gravity is pulling things in a way that's causing some of that pain.
Okay, so I'm gonna ask a question because I think it goes along with something you just said, and then I'm going to move into cramping and dystonia, because we're starting to get a lot of questions about that. So let me go back to, let me find it here. Keep getting more and it moves it around. So this person wants to know if you can speak about Camtacormia. Her husband has MSA and severe Camtacormia of his core muscles.
Sure. So Camtacormia, and you could almost say that that can kind of segue a little bit into the dystonia, in that. So Camtacormia is a term for that severely curved spine, the severely stooped posture that some people with Parkinson's and Parkinsonism, can develop. We see a lot less of it in the over the last 40 or 50 years since the advent of levodopa. I mean, it is primarily a result of rigidity, the rigidity of your core muscles, and the tendency that our spine does have some curve, and those tend to be the shorter muscles. And at some point, if you get curved over enough, now you're also fighting gravity, and there's a point at which if you have, once the your torso starts to bend, it's just too hard for those back muscles and those neck muscles to constantly work against, and they sort of give out. It can be very difficult to treat if it's not responsive to levodopa. But some of the things that can be helpful in, or at least are worth considering, certainly physical therapy and stretching, and trying to strengthen those back muscles. In some patients, a brace or a torso or posture harness can provide a little bit of benefit. And then in some cases, and I've seen, by personal experience, that the results can certainly vary from one person to another, but we have had success in some cases with botulinum toxin, or Botox, as people commonly know it, and essentially injecting sort of the abs and some of the hip flexor muscles to relax them and allow them to straighten out and stretch and make it easier for the individual to stand or straighten back up. But again, that's very dependent on how much range of motion and extension and extending or correcting that posture they still have. So.
All right, so lots of questions about cramping. Let's talk a little bit about dystonias, different types, where they might manifest, and then we can go back and answer some of these questions, because I have a feeling you might be touching on some of them anyway.
Mm-hmm.
So I'm gonna let you go through those, and then I've been loading these questions up, so.
Put my glasses on again so I can actually read my notes. There we go. So yeah, dystonia, and I'll put dyskinesia in there as kind of the other end of the spectrum. So what dystonia is kind of involuntary contraction of muscles or muscle groups that causes an abnormal posture. In movement disorders, I see folks who have dystonia as their primary diagnosis. They don't have Parkinson's. They have, their neck turns or pulls, or their eyes are always trying to shut, or their foot wants to turn when they walk, and then that's their whole condition. And in Parkinson's, we can see those kinds of symptoms as well develop over time. They tend to be related to wearing off or off time. So toe and foot cramping and curling, ankle turning and calf cramping, are all are probably the most common areas where people report that sort of, dystonia or pain. And it can happen as your meds wear out. Sometimes it's more of an overnight thing, and people wake up, early in the morning or first thing in the morning, and their foot or their calf is cramped or curled. But then on the other side, we have dyskinesia, which is, again, overactivity of muscle groups, but in this case, more related to the peak of your medication, sort of an overstimulation, if you will. And this can cause sort of twisting, gyrating, or fidgeting movements that, depending on how intense they are and which area of the body they seem to be focused on, can also cause pain. I have patients who have enough neck movement and spasm that they have quite a bit of neck and shoulder pain associated with it. And so in that context, so that's sort of maybe the most directly Parkinson's related pain syndrome or collection of symptoms. It's those kinds of cramping, spasm, and contraction that often seem to have a tie-in to either the peak of your medication or as your medication, your on time starts to shift to off time. And they're the first, the first sort of intervention is to look at your medication and see if maybe there's an adjustment to be made, either in the timing or the dosage of what you're taking, or potentially adding, another medication to help smooth out those highs and lows. Are kind of where we prioritize things. In more extreme cases, we may use something like Botox if it's a very specific and kind of a focal area, again, like your toes curling or your foot turning, or a patient who, I've had patients where we inject the neck, a couple of the neck muscles, because their shoulder and their neck always sort of pull to one direction. It becomes very painful for them when they have dyskinesia. And then on the extreme end, that's certainly also something where sometimes deep brain stimulation is very helpful in the context of, if you can, what does deep brain stimulation do? It helps get rid of the offs and kind of bring things into better, more consistent balance. And so therefore, for a lot of folks who have those fluctuations and have pain symptoms as part of that, addressing those ups and downs with DBS can be very helpful as well. But that kind of, again, it falls back to the better job we can do of controlling and managing your symptoms with whatever treatments we use. That's still kind of the primary way to address those kinds of symptoms.
All right, I have a few questions. I'm going to start off with one that actually just came in because you mentioned, the medication and trying to control the fluctuations. However, what do you suggest for someone who's confined to a wheelchair, has atypical Parkinsonism? So the typical medications, they don't respond to you. And this person's parent has been 3 years in their disease, severe rigidity and spasms in hands, arms, and neck. Already is using Botox every 3 months and gets a low dose of a muscle relaxer, but still in pain.
Boy, that is, that is certainly kind of the worst. Maybe not. I don't want to describe anyone as the worst case scenario, but that is a really difficult situation. And again, these answers are sort of, general considerations, right? But the interventions that I try to think about in those cases or in that situation are, so is there room to adjust the muscle relaxant? So there are things like baclofen, which has we have used for decades for, people with strokes and spinal cord injuries who have spastic muscles and pain associated with that. Other analgesics, sometimes it really does come down to, if we can't seem to improve or alleviate the underlying cause, say the rigidity or the arthritic changes or what have you, or the muscle spasms, then then we can at least do our best to try to just manage pain, and that may include opiates. It may include non-opiate pain relievers, there are a number of those, or anti-inflammatories. And in more extreme cases, if truly pain is the primary issue, there are pumps, either or spinal cord stimulators that may help alleviate that, and it becomes a pain management uh, picture as opposed to a Parkinson's management picture. And when pain is a disproportionately large component of what a patient's dealing with, I don't hesitate to plug in a multidisciplinary approach and encourage a referral to a pain management specialist to kind of have, just like I'd like to believe I have better understanding than most of how to use levodopa, dopamine agonists, and where DBS fits in. I would never try to say that about my knowledge of pain management. That's what a pain management specialist is there for, and they can be very helpful and useful. But that, I absolutely, my heart goes out to that question, the person with that question, because that is a very, very difficult scenario for both of them to be dealing with. So
right, and I thought it was a good question, just because there are people that join in that do have atypicals. They don't respond to this, the same way to meds, and yet they have a lot of issues. So
yeah.
It's very, very hard to necessarily address, but thank you for that. And I have a couple of questions in regards to cramping, several of them about cramps in the calf, followed by dystonia. Another person cramping at night. They have to get out of bed to get rid of it. Cramping in shins and toes in the middle of the night. So a lot of cramping in the middle of the night. And what can we do about that?
Right. So, what I'll do is I'll sort of run through how I would approach it if a patient of mine shows up, and this is the first time they've ever told me about it. And so typically those kinds of symptoms, as I said, tend to be related to being off or wearing off. If it's happening at night or overnight, the first thing I do is I look at, well, what medications are you taking? If you're primarily just taking levodopa, what different times are you taking it? Maybe if you aren't already taking a dose at bedtime, sometimes just adding a bedtime dose gives you enough carryover overnight to alleviate that. If that either doesn't seem appropriate, or they're already on a bedtime dose and it's still happening, then traditionally one of the things that has been very good at addressing that is adding something longer acting, like a dopamine agonist, and that would be something like pramipexole or ropinirole or the Nupro patch. So these are drugs that mimic dopamine and are in your bloodstream, fairly steadily over 24 hours. So they're there, they help they help smooth out the dips with your medication during the day, but they also provide a little boost of dopamine overnight. And sometimes that is more than enough to help or to prevent that kind of, off dystonia. So those are often, those are probably the things that you would start out with. Other medications that can be helpful, maybe more for daytime cramping or spasms. Sometimes the addition of something like amantadine can be really helpful. Amantadine is an old flu drug that turns out to have, for a number of reasons, some very, valuable anti-Parkinson's effects. One of the most useful things is that it's one of the few medications that seems to suppress dyskinesia, or the involuntary movement that people can develop when they're taking levodopa. But it's also, it can be very helpful for the wearing off cramping. And that's really 90% of of what is, of what gets that job done, is just looking at the medications and optimizing them, by which I mean minimizing the dips and trying to minimize the low points in terms of your meds, and maybe giving you something that carries through overnight better.
And, there's been a couple of questions. So if someone's neurologist isn't really comfortable or able to help them with this, what would you recommend to somebody who's really struggling to get through the pain, requesting a pain management referral?
Yeah, I mean, I think that's certainly reasonable. I try to always be, thoughtful towards various scenarios out there. But I mean, you have Parkinson's for life, right? So I think if you're in a big enough community where you can, you can seek a second opinion, or see another Parkinson's specialist. If you don't have good communication, or if you feel like you're not getting, sort of being heard, or any of those things, I honestly, if it's me, I'm gonna go, I want to get another opinion. I don't think there's anything wrong with that. I think you have, you should never feel disloyal by that. Sometimes that isn't the issue either. It's just, boy, this is the best person available to me, but this area is something that they're just not comfortable with. And if it's, if pain is the main issue, then yes, seeing a pain specialist is, we're asking if you could get a referral for that, may be helpful, for sure.
And before we move on, there's been a couple of questions in regards to maybe some other approaches, such as they asked about tonic water with quinine. Can that help? How about magnesium and alpha or ALA?
Right.
And acupuncture even.
Yes, and I think in varying settings. So certainly for the musculoskeletal pain, I think, massage, I kind of roll that in my own mind, but it is worth, stating out for everyone and being a little more specific. But that absolutely massage therapy, stretching, acupuncture, if if it's available to you, and and you have good, comfortable, competent, well-trained practitioners. I think all of those have been shown to be very helpful for various forms of musculoskeletal pain and cramping. It's maybe a little less clear how helpful acupuncture, say on a during the daytime, is, and maybe preventing, say, like nighttime calf cramping. That it could be helpful. I'm not saying that. It's certainly not going to be harmful, but it may not be. It may be, you may be more likely to be disappointed in terms of that outcome. Magnesium, calcium, those sorts of things at bedtime can help with certain types of cramping. But if we think it's truly Parkinson's related, I think it's still the most effective approach is trying to reduce that difference between on and your overnight off. I've I have patients who have sort of isolated but really problematic, uh, you know, muscle cramping, and they try all kinds of medications, and lo and behold, quinine really does help a small subset of patients, and it's sometimes the only thing. Uh, and certainly tonic water, it has a not insubstantial amount of quinine in it, but a very, I think, what you would call a pretty safe amount in it. So it does not hurt to do that. And of course, just making sure in general that you're well hydrated. You don't have to drink a whole bunch of water before you go to bed. We're all going to regret that if we do that. But if you drink enough water during the day, that is going to, even if you cut yourself off, mid-afternoon or early evening, you are less likely to cramp, because a lot of, even with dystonia, there's a component of that electrolyte issue that either makes it a little bit easier to cramp or a little less easy to cramp. So, if your urine looks like iced tea when you're going to bed, you're not drinking enough, and that's probably contributing to things. So that's always a good thing to remember.
Fantastic. All right, I want to move on to some of the other kind of pain, because we still have quite a bit to cover, and time is really flying. So nerve root pain and central pain syndromes, I kind of put those together, but I thought maybe you could touch a little bit on those.
Absolutely. And, they are, let's see. So, to a degree, Parkinson's itself, in some people, may actually affect the way you process pain, just like, sense of smell is affected and other sensation can be affected. And these are typically, it can be more of an all over body thing, or it can be more focal, it's often then kind of in conjunction with maybe an irritated or pinched nerve root or what have you. But this is that burning pain, or that's just sort of always there, and it flares up and down as the day goes on. Or sometimes it can be those kind of very sudden, sharp, kind of electrical pains that, don't seem to have a clear trigger, but can be very unpleasant and even a bit scary. And here, I think we're back into an area where it's less about, how well treated your Parkinson's is, and it's more about looking at it as a central pain syndrome or a neuropathic pain syndrome. And if it's, if it's kind of focal, we look at, well, what nerve is involved there? Maybe, if it's the back of your head and you get these horrible headaches in the back, the top of your neck and the back of your head, then maybe it's some combination of rigidity and arthritis that's irritating the occipital nerve. And you can try to, sometimes we'll use, trigger point injections or a nerve block. If it's more generalized, then that's where we might look at, say, the same kinds of medications that we use for nerve pain in other areas. Some of those are, borrowed from the antidepressant class of medications. Some of them are borrowed from the anti-seizure group of medications, gabapentin, things like that. Like the antidepressants, sometimes duloxetine, or an older drugs like amitriptyline. Those are all potentially, along with a handful of others, helpful in kind of resetting the dial there in terms of how your brain is perceiving sensation and what is painful and what isn't painful. So that it is more common, I think, than people realize in Parkinson's, though the approach seems to be more of the same approach one might have in someone with, say, a bad diabetic burning feet, or something like that, or some chronic, a chronic sciatic back pain and the like.
So you mentioned like burning, like neuropathy type pain, and I've had people say that they have burning pain. Is that related to Parkinson's, or is that a secondary issue? And burning mouth, like, might be rare,
Right.
but I've heard of burning mouth syndrome too.
Yeah, so the burning feet or the neuropathy, neuropathy has rarely been reported as, seemingly related to Parkinson's. There are even occasional reports, or a handful of reports, over the last 50 years. So, they're not super frequent, but they do happen, that people on really high dose levodopa, have reported neuropathy symptoms. And then if their dose is lowered, so we're talking like 2,000 milligrams a day. So that would be like 20 of your 25/100 standard, carbidopa levodopa tablets. It has been seen there, but it, again, extremely rare, and that would be very extreme case. My suspicion, I think for most of us, the suspicion is that in most cases, neuropathy, pain, burning, that sort of thing, is due to more pedestrian, if you will, causes. So, do you have, we do know that there is a little bit of a higher incidence of type 2 diabetes or pre-diabetes in people with Parkinson's. So, and diabetes can present as neuropathy, as the very first symptom folks have before anyone else figures that out. And the other thing, and this kind of goes to, what should your doctor be looking for? If someone presents with new neuropathy symptoms, burning, those sorts of things, I also check for other, reversible, preventable causes. So I check their B vitamin levels. I check, their thyroid, a handful of other blood tests to make sure we're not missing something sort of classic, but that sometimes is easily forgotten because we think of them as more of a historical or a cause. So I still see folks who who have remarkably low vitamin B12 levels, and they're having pain and poor balance and confusion and you name it. So, but relatively uncommon. You just don't, as a doctor, you don't want to miss it because it's something we can potentially actually cure just by putting people back on the right vitamins. I'm trying to remember, there were a couple of other things here on my list that I just want to make sure I'm not missing for that sort of the whole central pain. I think, because Parkinson's doesn't happen in isolation, it doesn't, it's not a free pass so that we don't get anything else. I have patients who late in life develop migraines, and maybe the rigidity and the stiffer muscles in their neck helps aggravate that. And so then, we need to address those migraines, or they're not going to have a good quality of life, and fibromyalgia and those sorts of processes can also, they can occur together. They're not, they aren't typically related, but they occur commonly enough that some people are just going to have both. And it's important to recognize and remember that as a, both as a physician, but also as a patient, that, sometimes, even though that Parkinson's is such a big piece of our life, in terms of our health, it isn't always, it's not, it isn't always the only thing going on. And so it's just my reminder that we always have to step back and look at, things outside of the context of just the Parkinson's, even though it's so natural to sort of want to tie things in. And that kind of flows into depression, maybe, and mood.
And that was going to be my next question,
Yeah.
because you kind of mentioned it a little bit already, and that certainly is an important thing to cover.
Yeah, and and the statistics are somewhere between 30 and 40% of people with Parkinson's, have enough depression symptoms that you would just that they would qualify for the diagnosis of major depression. So that in terms of intensity, duration, those sorts of things. And I think those are the most commonly quoted numbers. I think I've seen a couple of surveys that suggest that it might even be as high as 50%. That does not mean that half of people with Parkinson's are depressed all of the time, but it's that they may have a period where depression enters the picture. And absolutely there's a link between depression and pain. So there are changes in your brain chemistry and your processing of information that I think affect how we perceive pain, comfort, and that ties also into our energy level and our motivation, and sometimes it's the pain that is the horse and the depression is the cart, and other times the depression is what's leading the way, and it is causing an amplification or a worsening of your perception of pain. And so it's important when, especially, if you're finding, gosh, I'm achier all the time. It hurts more to get out of bed. And it's, I think often it can be a little more of that general pain, that sort of everything hurts and whatnot. Though, if you have a bad back and you're depressed, your back is also going to hurt more. So one of the things that I always try to do is get a feel for, aside of the pain, how are you doing emotionally? How is your outlook on things? And then the next big tie-in, which again, sometimes it's the horse, sometimes it's the cart, is sleep. If you're not getting good sleep, it's hard to, that affects serotonin, it affects dopamine, it affects your mood, your energy, and it affects your pain processing. And if you're hurt, conversely, it can be hard to sleep, right? It's hard to get comfortable and the like. And I don't say it this way to make it sound like, oh, it's impossible to know which is the problem. I say that because it's important to address each issue. And probably that's, I think it's easy to get into the trap of, well, I need to figure out which one's causing what, before I can get better. I think what's the most effective approach is to realize that they're probably all happening in conjunction with each other to some degree, and they're feeding each other, unfortunately. And so to try to just address one may never be as effective as saying, you clearly have, you clearly have symptoms that indicate that you're having some depression, you're having pain, and you're not sleeping well. So let's be systematic about it, but probably at the end of the day, we need to address each of those issues. And then once we get you feeling better, then we can kind of, decide where we can back off or and kind of untangle that net a little bit. But the first thing needs to be to try to turn that tide.
This is really good. And everyone's like, we need part 2, 3, 4.
That's just because I yammer on and on.
No, but
Sorry.
your yammering is a lot of great information. I don't know if you have to rush off. I really have several questions. So if people want to hang on for a little bit, I want to try to go on just a little bit and go through these things, because I think this is such an important topic. So I want to talk a minute about, and I never say this right, akathisia. Is that?
Yeah, akathisia. Yeah.
Yeah. Can you talk about that? And is there any relationship to pain? And can you explain what that is to people?
Sure. Akathisia is kind of a very specific syndrome. It's a restlessness, and an inability to really sit still. There's often some feeling of discomfort, and yet it's a bit different than, say, restless leg syndrome, which is mostly about the unpleasant feeling that you're trying to get rid of by moving. And it's different from dyskinesia, which is all about involuntary movement and not really about much of a sensation that's driving it at all. Most typically, we see akathisia more in the management of, say, psychiatry patients, things like that. So folks that are on, dopamine receptor blocking medication. So most often, most of those are antipsychotics. And these days, those kinds of medications are used a lot more widely than they were 30 or 40 years ago. So we have people with chronic depression, anxiety disorders being put on maybe an antidepressant and a dopamine blocking drug. And occasionally, I have had a Parkinson's patient show up at my office, and they have been put on, a dopamine blocking drug by a well-meaning physician, whether it's their primary care doctor or a psychiatrist, who maybe just didn't realize the interactions there. But certainly that's probably the most common one or situation where we run into that. And there it's all about, either, tapering off of that drug, or in some cases, if there's particularly in someone who doesn't have Parkinson's, if they present to me with that, then we may try putting them on something like amantadine. Is often helpful. The other medication group that maybe does come into play a little more in Parkinson's can be the anticholinergic drugs. So that's like Artane or trihexyphenidyl, or benztropine, which is cogentin, and then to, I think, a much lesser extent, the Benadryls and things like that, which kind of have that, any of the things that give you cotton mouth and, kind of those sorts of symptoms. Those are typically have some anticholinergic activity. And in some patients, it does bring out that movement, which can be, while usually not dramatic, it's not going to hurt you per se, but it can be very unrestful, kind of unpleasant, and very annoying, to say the least. Mm-hmm. So that's almost always sort of medication related.
Okay. Is there a situation where it might just be a part of the disease? And is that feeling of like inner tremor and like a buzzing that I've had people say that they've experienced, is that part of that?
So that's a very good question. And I would say I believe that for the most part, I think that is something different. I'm not sure, sometimes it's just, it truly is your resting tremor that, it isn't, the amplitude's not big enough for you to see it or for most people to see it, but you can feel it, and it isn't, it is possible to have or be aware of a resting tremor in your, in your torso, or in those muscles in certain positions, and if it tends to go, to be dampened as you move and move and get out of a chair or turn your body around, that makes that much more likely. I've also had patients when they have dyskinesia who have some kind of a a vibrating restless feeling, and it's not clear, is that just the muscle movement and the overactivity, or is it more of an internal sense of being kind of overstimulated, right? um and but there again, it's a little bit of, what helps me figure things out usually is kind of, well, what else is, what's the company it's keeping, right? So boy, that only happens, I notice at the most an hour after I take my pills, or I notice at the most first thing in the morning when I first get up and I haven't had any pills yet, or those sorts of things help clue you as the patient, but also me as the neurologist, into maybe where this is coming from, or what the source of the issue is.
Okay, thank you. So from a dietary perspective, is there anything that people should be avoiding that can increase pain? I'm thinking sugar. But are there foods that they either should avoid or might be helpful?
That's actually very good. And we could also mention, I'll just throw out there, GI motility can be a pain issue as well. Severe constipation, bloating, those things are all uncomfortable. I think absolutely, that the tendency, intended or unintended, to sometimes shift away from protein and towards carbs and sugars can be problematic when it comes to pain. Not that, the sugar itself is pain, causes pain, but that up and down of your blood sugar, and maybe that tendency to crash, I think can aggravate pain symptoms. Again, hydration is maybe the most, the best thing you can do from a dietary standpoint, or nutritional standpoint, to avoid or reduce pain symptoms, in that I think, it reduces cramping, reduces severity of a lot of musculoskeletal pain. And then, I think fish oil has been known to have some anti-inflammatory effects. Making sure you're getting a well-rounded diet in terms of, getting the vital nutrients, vital vitamins, and the like. And if you haven't had your vitamin levels checked in a long time, or maybe ever, I think there is some value to doing that, to make sure that on top of having a balanced diet, you're actually absorbing those vitamins. And I don't routinely tell folks to take a multivitamin on a daily basis, but if you're low, that can be valuable. Or taking, a supplement that has the specific vitamins that you are low in, can be valuable. I'm trying to think and then, yeah, again, maybe, avoiding or not overloading on carbs, simple carbs and sugars, is going to be helpful in terms of, the constipation and the motility issues as well.
So maybe following the like Mediterranean diet or the Mind's diet, or
Yeah, or or the coloring book diet. Get your veggies in, get as many different colors in. Try to eat fresher, more fresh food when you can, and trying to avoid things that are going to bind you up, or um, and making sure you're drinking enough, and water. And when I say water, I mean that can be juice, that can be other things. It doesn't always have to be just plain boring water if that's the part that keeps you from drinking it. But it shouldn't be beer, probably shouldn't be coffee, shouldn't be things that also have a good diuretic effect.
Right. All right. So one thing we haven't touched on as far as treatment, but you talked about it before with Lori, and that's medical marijuana.
Right. So, and again, this is, the country's changing, culture's changing. Not that many years ago, there wasn't even a point of bringing it up. But there is evidence that, of some of the best evidence for the medical use of cannabis is probably around pain. There have been actual, clinical trials looking at that and published. As if I'm going to try my best to sort of break up the value of maybe THC and CBD, it does seem like CBD's best effects are related more to the neuropathic components of pain, so that central pain, the burning nerve pain and the like, where maybe THC seems to have a more specific benefit or effect in other forms of pain, so the musculoskeletal pain, arthritis pain, that sort of pain. I will say I wouldn't go too far out on a limb to tell you how distinct that difference is, but I think there is definitely a role there, and I think it's something where I think the downside is not terrible. It's really probably limited to, do you have a bad experience for a few hours? If the formulation that you tried just was not a good fit for you, and you just felt, either weird or stoned or a little paranoid. The good news is that clears up. I think in terms of tolerability, if you are going to use THC containing, cannabis products, the ones that are more closer to a 1-to-1 ratio, or that contain a similar amount of CBD, probably tend to have less of the sort of psychedelic effects that maybe we aren't out for in this kind of situation. And from there, probably, again, I think, as we said last time, you probably most of us don't want to smoke this. The edibles can be a little bit difficult to gauge in terms of how quickly they're going to work, how long they're going to act. Maybe the oil concentrates that are sublingual for this situation, for kind of real medicinal use, probably make the most sense in terms of being able to adjust the dosage and kind of have a predictable onset and effect. So
awesome. Well, I know we've gone over a bit. I think it's well worth it. I kind of want to go back and summarize, because you've covered a lot. And what I heard, and I think that I'd love you to kind of just give a final synopsis is, with all these different pains, it may take a different disciplinary, in a multifaceted approach. It may require pain meds. And then if you have constipation issues, then working on to mitigate that. There's exercise, there's diet. There's so many different, there's not a one size fits all kind of approach. And I know that's kind of frustrating because we would like to be able to say, here's the golden nugget pill for you to get rid of all of this pain. But do you have like a final way that you would like to kind of summarize all this?
Yeah, I mean, I'll do my best. So I think, first things first is if you are having pain, it's important to bring it up, right? So can't do anything about something until you recognize that it's there. And to to maybe treat it as as its own entity to begin with. It may be that it is directly related to your Parkinson's. Be your own best investigator. Note as best you can. Is it all over? Is it really more focal? When does it happen? Is there a relationship to my Parkinson's medication or my other symptoms? And is it new? Has it been there, in the past or not? Those sorts of things. And if you do those things and are also doing doing your best to do the preventive care things that we always talk about, drinking enough water, taking care of your GI system, exercising and being as active as you can, and you're still having these symptoms, then coming with those other details to your doctor will make the best use of whatever segment of that visit that the two of you are able to allot to that, and you'll get to the bottom a lot faster. And I think having an open mind, I think before you get there, it is helpful too, so that even if you're pretty sure that this is not my Parkinson's, this is something else, if your doctor says, boy, I think it is, don't be afraid to have the conversation and make sure that you understand why they think that is. Pain is, the more afraid and the less we know about what's going on, the worse pain is actually. So it's important that we all feel like we're in on this together, both as a patient and a doctor. And the more specific info you can bring, the happier your doctor will be. And I think the more time there is to discuss the whys too, which I think for me as a patient makes me a lot happier, and more confident that what we're going to do is going to get us down the right track.
Awesome. I want to thank you so much for being a part of this discussion today. We covered a lot. I thank you for staying on. I thank everyone for joining us today. So for those of you who wanted to know, yes, this is recorded. It should be up on the website in the next few days. So if you want to go back and review it, if you want to share it, that's a great way of doing that. If you want to save the chat, just in case there's some things in there that you wanted to catch, if you go to where you chat your questions, over to the far right, the three little buttons that says more, you pop that up and you have the option to save the chat. So that's important for some of you if you want to keep that. And then, of course, I want to thank you so much, Dr. Samanta. This has been a really good conversation, and I think you really shed a lot of light on things. So thank you for spending the time the extra time especially. And if everyone would be willing to give the wave of gratitude to Dr. Samanta, I have to thank you so much because this has been great.
Thank you. It's always my pleasure. And, you know, I love the community that we have here. And I'm always honored to come on. So thank you.
Well, yes. We will have you back. Part 2, 3, and 4.
I'll be there.
All right, awesome. Well, everyone have a great Friday, great weekend, and we will all see you next week. All right, bye-bye.
Bye.